Hi, my name is Shauna Mitchell, and I work for PANDORA, and we advocate for patients with neuro-endocrine-immune disorders. And my question would be, with the stipulations surrounding opioid addiction, not dependency, how do legit chronic pain patients go to the ER without being seen as drug seekers? How do we balance abuse with abuse? Because these patients are being abused because they're not getting the drugs that they need to not be in pain. And suicide is a very real situation from this that develops.
David, do you want to answer that?
I'll take this, David. Yeah, I think when as a primary care provider, my other hat 5 years ago, if my patients sought care for their pain condition in an emergency department, that was a failure of my ability to anticipate the pain management. I was doing a poor job. The data suggests that 25% of patients get their chronic illness management in an emergency department, and that's just not a suitable place. So the short answer is, if they go into an ED to get adequate pain control, the problem is at the primary care site, and they need to be enabled to be able to provide more effective care at that level. Emergency department is just a very chaotic location. Prescription drug monitoring programs have helped because they can identify the patients aren't shopping around for meds. So that's been a first step in the direction to decriminalizing the patients who are actually seeking bona fide relief.
The other David.
Right, the other David. But that is a real problem. I mean, with sickle cell pain, there'll be an acute episode, and a person will go to the emergency room and won't get help. They'll be looking like they're drug seeking, and that transcends the whole field. I mean, pain patients looking for opiates and drug addicts looking for opiates, they're kind of acting the same way. So trying to differentiate them does cause problems, especially for the pain patients that are just trying to get some relief. So some things we're doing is in terms of education and ways to distinguish, ways to raise the awareness of healthcare providers about how to identify the difference and know that there's kind of a continuum in between, that it's not just one or the other, but there's a lot of things in between. So part of it's education. And then at the NIH, if we could come up with tools to better identify pain, because as I said before, pain is a real thing, but we have to rely too much on self-report. So if there's other metrics that would give more confidence to even in the emergency room, you come in, you say you're in a lot of pain, and there's a little test or something that would at least be confirmatory to some degree, it might give the healthcare providers more reason to trust you and to treat you.